Good afternoon, everyone. My name is Morgan Gargiulo from the New England QIN-QIO, and I will be your moderator for today's webinar, Shot from the Heart, Flu and Pneumonia Shots and the Importance of Continued Vigilance. The QIN-QIO works with healthcare providers, stakeholders, and communities across New England on data-driven quality initiatives to improve patient safety, engagement of patients and families, and to improve clinical care at the community level. So thank you for joining us for today's webinar. Before we get started, I wanted to go over a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. I have placed the phone lines on mute for the duration of the presentation. However, if you could also manually mute your lines, just to make sure we don't get any feedback, we would greatly appreciate that. We will be taking questions at the end of the presentation, and I'll provide you with instructions on how to unmute your line at that time. Or you can always pose a question in the chat box on the right-hand side of your screen throughout the presentation, and we'll review those at the end as well. At this time, I'd like to introduce our presenters for today's webinar, Roby and Cooney, both from the New England QIN-QIO. And with that, I'll pass it over to Russ to get us started.
Good afternoon, everyone. Welcome to Shot from the Heart, Flu and Pneumonia Shots and the Importance of Continued Vigilance. My name is Russ Cooney, and I am the task lead for adult immunization at Health-Centric Advisors. The objectives for this session are that you'll understand the immunization cycle, a timeline of incidence of influenza and when it peaks annually. You will understand the relationship between timely immunization and decreased avoidable admissions and readmissions to the hospital. You'll be able to encourage all eligible persons to be immunized in a timely manner, and you'll also know how to counteract vaccine hesitancy. As you can see, the peak for confirmed cases varies from year to year. This is the number of confirmed cases from 2013-14 through 2015-16. So far, 2016-17 is tracking most similar to last year, the 2015-16 season, and last year's peak was in mid-March. Widespread flu activity is now reported in over 25 states, according to the CDC, per a CNN report on January 3rd. This includes 4 out of the 6 New England states. Currently, Maine is seeing regional activity, and Vermont is still seeing only local activity. Widespread means more than 50% of geographic regions in the state, counties for example, are reporting flu activity. It addresses the spread of the flu, not its severity. However, 20 states experienced a high proportion of outpatient visits to healthcare providers for flu-like illnesses. This year, the most common strains have been H1N1 and H3N2. Last year, 381,000 people were hospitalized and 171 children died in what's being called a relatively severe season. However, the CDC estimates that flu vaccination prevented 6.6 million illnesses last year, 3.2 million doctor visits, and at least 79,000 hospitalizations. Just a reminder, antiviral medications when taken early, is recommended for patients with confirmed or suspected influenza who have severe, complicated, or progressive illness, who require hospitalization, or who are at high risk of serious influenza-related complications. This increases the risk of medical complications for the most vulnerable patients, especially those with chronic illnesses. So anyone you can get immunized over the next 4 to 6 weeks would benefit greatly. So on this slide, you can see the peak for flu seasons can vary from year to year. Just as an example, last year, the peak did not occur until March 12th. And it looks like this year is very similar to last year in the pattern that we're starting to take. The CDC will be publishing the vaccine effectiveness data in mid-January, which should give us a good indication of the effectiveness of this year's match. Some of the factors influencing getting a flu shot include cold weather, convenience, transportation. It also includes, unfortunately, myths and misinformation. And the media sensationalizing when there's issues. And of course, there's always the confusion about the different immunizations. We need to kind of get creative on how we approach our patients. Anything we can do to mitigate these factors will help. On average, only 2 out of 5 people have gotten their flu shot this year. So if you look around the room that you're in right now, imagine only 2 out of 5 being immunized. There's still a substantial risk out there. So the more we can get people vaccinated, the better. Kathy's going to talk more on this in a few minutes. So how do you counteract hesitancy? One of the single most important factors is a strong provider recommendation. Also using promotional materials that expound on the benefits of immunization, such as protecting elders and infants and those with chronic conditions, herd immunity, things like that. And you want to be willing to share your own reasons for getting a flu shot and how it's handled in your practice. That personal connection can sometimes make all the difference. By being open and honest with patients about their questions and concerns, we can keep open the channels of communication and increase the likelihood that they'll get immunized. Leaving things out or cherry-picking answers will only increase this hesitancy. So I'll now pass the ball on to Kathy to speak more on the data and the plan going forward. Kathy?
Thank you, Russ. Thank you, Russ. Can you hear me?
Yes.
If October has always been the flu shot prime time season, the question we want to ask is, so why are we talking about this now? And Russ has already shown us that in the previous slide, the peak of the flu season last year was March 12th. That's literally 8 weeks away. The CDC is predicting that the flu prime time or peak of the season is actually going to be March 14th. Just a 2-day difference. So in the next 8 weeks, we need to do everything that we can in order to ensure that the least number of people possible get the flu. When you look at Russ's slide from earlier, what you are seeing here is the peak for positive confirmed cases. If you look at these colors as they advance on your screen, what you're going to see clearly documented here is that the peak of the flu season is January, February, and now March, with March seeming to be 2 years in a row the very peak of the season. Next slide, please. Russ has already talked a little bit about the relationship between immunizations and acute care hospitalization. Here at the QIN-QIO, we tend to look at everything in the context of what does the data tell us. For those of you in physician practice, for those of us who are out in the home health and hospice communities, we are tracking our acute care hospitalizations and our emergent care episodes. And we are clearly seeing that there is a data-driven relationship between the percentage of our patients who are properly and timely immunized for influenza and pneumonia and a reduction in the number of emergent care and acute care readmissions. So we believe that we can demonstrate to you that there clearly is a relationship. Next slide, please. In preparation for today, I went through the data and I took a very close look at the hospitalization rates in the 6 New England states. I compared those to the risk-adjusted rate for the whole country as a whole. Each of the states is listed here, and for the sake of our slide, I have not identified the numbers that go with each state. Let's take a quick look here at how these numbers shift month by month within each state. State number 1 at the top. This is their hospitalization rate. Compared to the national rate, it is literally double in January. And although it does decrease slightly in February, March, and April, it is still nearly double the national rate. So why? And Russ has actually already told you that there is a focus of increased confirmed cases of influenza in the Northeast region. So here it is. The flu is here, pneumonia is here, acute care hospitalizations are rising. As you look at each of the states, you will see that states number 5 and 6 have the lowest number. They are closest to achieving the national risk-adjusted rate of immunization. Hold that thought as we move to the next slide and we consider now the immunization rates for those same 6 states. Nationally, the immunization rate for influenza is 72.7, nearly 73%. For pneumonia, it's 75%. In other words, 3 out of every 4 people in the room that was eligible had a pneumonia vaccine. Nearly the same 3 out of 4 had an influenza vaccine. Let's look at states 5 and 6. Look how close they are. They, in fact, exceed those national averages by a significant amount. And they had significantly lower hospitalization rates. Take a look at state number 1. The highest hospitalization rate and the lowest immunization rate. 69%. Only 2 out of 3, as opposed to 3 out of 4, received an influenza vaccine in this particular state. Clearly, there is a data-driven relationship. Let's ask ourselves why. What is causing these patients who are not immunized to be admitted to the hospital? Let's move to the next slide. The 3 most frequent causes for unplanned hospitalizations, according to the admissions data gathered by CMS, are respiratory infection, respiratory distress, congestive heart failure. Clearly, these are directly related to influenza and pneumonia. There's a direct demonstrated relationship between higher immunization rates and lower hospitalization rates. There's a clear drop in hospitalizations following the October immunization campaign. If you look 6 weeks out from the peak of immunization clinics, which tends to be from the 25th of September to the 15th of October, that's when you see signs for flu clinics everywhere. There are lines at CVS and Walmart and the Rite Aid. There are lines at the senior center when the nurses show up to give flu shots. You don't get as much resistance in your office when you're asking your patients when they come in to get a flu shot. And the hospitalization dip 6 weeks later. And yet, in quarter 1, January, February, and March, those 3 out of 5 people who chose not to be immunized are getting sicker. And the acute care hospitalizations are rising, and the causes, documented, data-driven causes, respiratory infection, respiratory distress, congestive heart failure. Next slide, please. So what can we do about this? I've always been a person who, if you present me with the problem and you prove it up, that definitely something needs to be done, then I want to act. I don't want to sit around and let's have a lengthy conversation. So what could we do? We know that all the advertising, all the conversations, all the pushing and the papers and the posters and the buttons and everything that we've done has made that October flu shot primetime season very effective. I think it's time for a second season. We need to create and develop an impetus behind an immunization initiative, a second season. We need to tell people it's not only not too late, it's prime time again. So what can we do to develop an action plan? Our first step is to identify who are the people that are at risk who have not been immunized. In your setting, in your part of the healthcare continuum, how would you go about doing that? If you are a physician practice with an electronic medical record system, if you're not sure how to do it, get in touch with your vendor and don't let him get away until he tells you how to run the reports that can tell you who on your caseload has not been immunized for flu and pneumonia and is eligible to receive that vaccine. Then we need to think about how we're going to overcome that hesitancy that Russ spoke about. What are we going to say and do that's going to reach them, going to convince them, and then get them in there to their office to be immunized in a quick and easy fashion? So we need a theme. Any kind of an initiative has got to have some kind of a theme, some kind of a motif that is going to be quick and catchy and get people's attention. If we can almost literally distract them with that, we can take the first step toward overcoming that hesitancy. Something simple. Don't get the flu, get the flu shot. Whatever you choose, how you choose to phrase it, you need to create that theme. Then you need to build your education and outreach material around that. The CDC, the American Lung Association, the World Health Organization, and a multitude of others all have tremendous free education and outreach materials that you can access and weave into your theme and your process. Speaking of process, once you get these people's attention, once you get them nervous enough to be motivated, to not be hesitant and uncertain, but now want to get their flu shot, want to be part of the second season, how are you going to schedule and immunize them in a way that is going to be quick and easy and not discourage them from coming in? Because if they agree to do it and call your office and can't get an appointment until the 1st of March, we haven't accomplished anything. If they call your home care agency and say, where can I get a flu shot? And you say, we don't do that. That's not quick and easy. That's not helping. Think about what kind of a process you're going to use. Have it in place before you send out your education and outreach materials. Before you start making phone calls to everyone in your caseload that did not get a flu shot. How will you do this? Recently, I had a reason to stop into my family practice office myself. They have had posted over one half of their check-in window a sign that said, Easy Pass Flu Lane, for people who had an appointment to get their flu shot. All they needed to do was to walk in, show their insurance card, give their name, they received their influenza consent form, filled it out, and by the time they got into their signature, they were already being called. I watched people in, get their flu shot, and out again in 10 minutes. Can you do that in your office? Can you create a system and a process for an Easy Pass Flu Lane for your patients? What about for those of us who serve other people out in the community, whose patients don't come to us? We go out to them. You need to think carefully about how you want to do that. Can you get standing orders? Can you get an EpiKit so that you can send your nurses out into the community to work on getting people immunized that have called your agency and asked for assistance? Can you run a flu clinic this winter? Consider how you will do this, how to create the process, how to get the visit scheduled, and how to get this done. For those in the home health community, I have done a great deal of work on a one-to-one basis. If you're interested in attacking this problem, after this program is over, reach out to me at the contact information at the end, and I'll be happy to work with you on a one-to-one basis. Once you've created your theme and your process, educate and motivate your staff. It's not going to be very successful if your own staff did not get immunized and are busy saying under their breath, well, maybe you, but not me. What was your decision as a health care provider? Did you require all of your staff to get the flu shot, to get a pneumonia vaccine if they were eligible? You should first consider this because you don't want to be sending out a mixed message. You don't want to be telling your patients and your clients that you need to be immunized, but not me. So make a plan, make a decision, and then first educate and motivate your own staff, develop the theme, all the materials, create the process, and then reach out to the patients that you are responsible for. You want to have as a goal that you will have conducted your outreach, your education, and immunized as many as possible between today and the next 4 to 6 weeks. Your target should really be between the 20th and the 28th of February to complete this project. And always include in your handouts and your education handouts and flyers on effective hand washing and practicing infection control. If you go to the World Health Organization, the WHO website, and in their search box you type in clean hands saves lives, it will take you to a website where you can order free, that's right, no cost, 8.5 by 11 sheets with instructions for the 7 steps for hand wash and hand rub. Post them in every bathroom, on every door in your office. Hand them out to every person you come in contact with. And then continue to gather the data on how your practice, your agency is doing on immunizing your patients and looking at what percentage of them are still going to the emergency room or to the hospital. Because you want to investigate every one of those to look at the why and be sure that you have done everything you could possibly do to prevent that emergency room trip or that hospitalization. Next slide. Russ, I think this one's yours.
Yes, it is. As Kathy was talking about, standing orders is an important part of your practice. This slide shows the intervention to increase immunization as top of the site organizational change, which includes the standing orders and having separate clinics, as Kathy had just said. If you don't have standing orders, you may want to consider it. We're going to provide a lot of resources at the end to help with this process. But some of the simple things is 10 steps to implementing standing orders for your practice. There's using standing orders for administering vaccines and standing orders for pneumococcal vaccines as well as influenza. If you're able to do these things, I'm sure your immunization rate will go up. And as Kathy had said, that example of the Easy Path is a wonderful one. I recently went to a specialty office, and unfortunately, they do not immunize their staff, and they don't have a process. And that, unfortunately, sets the patients up to become infected through the provider. So anything that you can do to help promote immunization in your practice, and for people to have the convenience and the ability to go in and out quickly would certainly help. So, Kathy, do you have some helpful hints to share?
I do. I'm really one of those people that thinks that if you can get a short, simple, catchy theme, you're going to attract people's attention. How many times have you heard a buzzword, a phrase in a commercial? And hours later, it's still racketing around in the back of your head. So look for a catchy theme. It's almost February. Heart Health Month. Heart health starts with you. Get your flu shot today. Order up buttons. People do still wear them. Buttons for all your staff that say, I got the flu shot instead of the flu. Look for those flyers. The American Lung Association, the CDC, they all have them. And you can customize that flyer that says flu facts, why you should get your flu shot today. Make the process as easy as it possibly can. Physicians' offices, nursing homes, hospitals, home health providers, we all should first make sure that our staff is fully informed, fully supportive, and they all, as many as possible, have gotten their own flu shots. The next step is that we need to work together. We need to communicate better to one another. If a patient who's traveling across our continuum has gotten a flu shot in the hospital during a rehab stay in a skilled facility, we need to know that when they come back to the physician office, when they are seen by their home care provider, we need to know that they had that flu shot, they had a pneumovax when they had it, and there was no reaction. We cannot rely on our patients, as much as we'd like to be able to remember to tell us these things. And those of us out in the community, without as much bricks and mortar, physician practice, home care providers, community service agencies, we all need to work together too. We need to be sure that it's well documented in our records, whether it's a sticker, brightly colored, somewhere noted on a face sheet that this person has or has not had a flu shot or a pneumovax. What about the very few people that are not eligible for whatever reason? You need to make sure that those files are marked so that we're not continually asking them, but instead with those people should be focusing on proper hand washing, infection prevention, avoiding crowded places, so that they are not getting exposed to something that they are not able to be immunized against. But we need to work together. We need to communicate better. We need to help each other to get standing orders, to get responses back, and to make sure that the system works as quickly and effectively as we possibly can for the welfare of our patients. Next slide. If we coordinate together between physician practices and community-based providers, we can identify all of the at-risk patients. We can establish reportable assessment parameters and emergent care orders that will enable the community-based providers to manage care in-home to reduce acute care hospitalization. So that when a patient is first picked up as a home health patient, if physicians and the community health providers are communicating effectively, there will be a very simple, clear communication. This patient has CHF. If they get any kind of exposure to the flu, if they become symptomatic, if you have emergent reportable assessment parameters and emergent care orders, you can keep that person safely at home most of the time. Make sure you have simple, easy to read, easy to follow handouts. I can't tell you how really effective those tools are that you can get on the World Health Organization website. I get so excited when I go out to visit providers, go into the ladies' room, and on every door in there is the hand wash, hand rub poster. When I walk into a conference room or an office and I see the Purell on the desk, I see the sign on the back of the door. This is what we need to do. We need to find simple informational handouts with pictures, cartoons, whatever. Something that will remind people. Sneeze into your sleeve. Use a tissue to open bathroom doors. Anything simple like that. And then, simple first aid steps. How to recognize what symptoms they need to treat, what symptoms they need to notify the physician for. We need to also look at a call the nurse first methodology, whether it's in your physician office practice or your home care agency. We want patients to think. Follow the simple steps. If you have these symptoms, call the nurse first. Set someone aside, designate someone in your practice who's going to be the first line of defense, the advice nurse in your practice office, so that when those calls come in, someone is available to take them quickly, give them some practical advice, squeeze them into the office to be seen before they panic and go to the emergency room unnecessarily. If we educate them, they will follow through. They'll call us. They'll follow our instructions and hopefully stay well enough not to have to go to the emergency room. Next slide, please. Why is this so important? Go ahead, Russ.
So why should we do this? Why is this important? Information on quality reporting is becoming more publicly available, and when recent changes in pay-for-performance billing, you want to position yourself to be the go-to provider for patient-centered medical homes and neighborhoods. As you all know, people do look at the 5-star rating. You want to make sure that you're able to keep your rating where it belongs, and make sure that hospitals and ACOs and practices see that you're the one that they want to turn to. By getting into these partnerships, it can only benefit your agency. There are also the increased risks, increased ED use, as Kathy was speaking about, medical complications for your patients, increased hospitalization, and an unfavorable public perception. Last thing you want to be is that one agency that doesn't have what is necessary to provide the care for the patients when a provider is looking for it. So why should we do this? All of these reasons on this slide, but also because it's the right thing for the patient. You want to make sure you do what's right for the patient. In February and March, a lot of people get hospitalized for pneumonia, for the flu, and all the complications for all these chronic illnesses that are out there. We can save lives by doing these simple steps, so I believe it's really worthwhile to do. So if we work together, we can make this second season initiative as successful as October and bring down that spring peak of immunization in influenza. It's really important that we get everything out there and we're able to share our experiences and make it easier for everybody, including the patient and the providers. Kathy, did you have anything you'd like to add?
I think that's it. I can't stress enough how important it is. We do not have a shortage of vaccine. It is possible to obtain vaccine. If you have any questions at all about how to get it or where to get it, you can contact us or you can contact your local Department of Public Health, and they should be able to guide you. For those in the home health community, your professional advisory committee medical director can assist you if you need a script to obtain that vaccine. If you need assistance with writing policies or procedures, please contact us. This is really not that scary if you've not done it before. It is not that difficult to do, and it really can be a very effective process. If we work together, we can make this very successful. We just need to remember, March 14th is not that far away, and we want the spring peak this year to be the lowest it's ever been. We'd like to see it not even show up as anything more than a bump instead of a peak. So if you need anything from us, please give us a call. Thank you.
Morgan, can you please let participants know how they can ask a question?
Sure. Thank you guys for that great presentation. If you do have a question, You can put it in the chat box, or you can press #6 to unmute your line and ask your question. While we wait for folks to figure out if to decide if they have a question to ask by pressing #6, we did have one question come in chat from Jay. He said, do we have published data on what % of immunized patients get hospitalized because of a failed immunization? And he said also immunization rates for flu and pneumonia have more than doubled in the past 7 years. I would like to see data on reduction in hospitalization rate.
In home health, we know that the hospitalization rates have progressively come down over the last 7 years. I myself have been with the QIN-QIO for 10, and the hospitalization rates in general have progressively gone down in the 10 years that I've been looking at them. I don't have any specific information right here today about whether or not that I can give you about hospitalizations related to immunization failure. Russ, do you have anything?
Unfortunately, a lot of the states use Sentinel data when figuring out what their rates are, and that's only a small portion of the total population, so it's very difficult to get on any type of data in that regard. I think the best thing we can do is look at the number of people who have been hospitalized, the number of infections, and really look at what the overall impact is. At some point, we will get to where we're able to measure all of that data, but at this point, I don't think that's possible.
All right, that was our only question in chat at this point. Again, if you wanted to ask a question on the line, please press #6 on your phone and it will unmute your line and you can ask your question. Doesn't look like any questions are coming in, Russ. It looks like there's a few more slides. I didn't know if you wanted to advance through those real quick before I close out, or what you wanted to do with those.
Actually, it looks like there is one more question, Morgan. Steve is asking, is there a plan for Rhode Island Department of Health to make PCV-13 available to long-term care facilities? Has Rhode Island Department of Health issued any mandates for long-term care facilities to offer PCV-13? At this point, I can't really speak for the Rhode Island Department of Health, but I know that they are looking at the cost effectiveness of the PCV-13 because it is quite pricey. And I know that that's part of the conversation for next season, but I'm not sure if it's going to be happening this season. I know that the last time I looked, it was not available. So this next slide has a lot of the resources that are out there, either through the CDC or the Immunization Action Coalition, on different handouts that you can give to patients. And some of them are unbranded. So I know a lot of people can be hesitant about taking information from scientific journals and from the World Health Organizations and things like that. If you can get unbranded material and material that people feel more secure with the information, I think that helps also when it comes to the hesitancy. As I said earlier, there is a lot of information here on standing orders, and if you have any questions or if you're looking for any data or information at all, feel free to give Kathy or I a call, and we will make sure that we get back to you right away. Does anyone have any other questions?
Russ, I did point people out to the QIN-QIO website. I think Morgan's going to show that in a moment. In October, we did do a webinar with some very specific instructions for home health providers on how to go about setting up an immunization program, complete with process and other specific details. So if they go to the website, you will find that there under previous webinars.
Okay, thank you.
Alrighty, if there are any questions, again, it's #6 to unmute your line. Oh, it looks like another one came in chat. Let's see. We got one from Cindy. She said, as a new infection control officer, I have committed to improving our vaccine compliance rates with staff in our clinic. It has been a lot of work. Do you have any comments on non-immunized staff who should be wearing masks and when and how to address non-compliance with mask wearing? Also, may we obtain copies of the slides? The slides are posted on the website. I'll go ahead and add that link into chat again. Russ, I didn't know if you had any thoughts on non-immunized staff.
Well, the state law, at least in Rhode Island, is that if we are in widespread mode, then any staff that are unimmunized have to wear masks. Now, you really need to take a hard line when it comes to staff with the mask, because if you don't, then it makes the law ineffective. I think that when you walk into an office and you see someone without a mask, you need to point it out. You need to say something, because then people will realize that the patients are concerned about it, and it has to be a bigger issue. And hopefully the physicians are kind of leading the way and giving a good example to people on the importance of having their immunizations, and make a huge public thing where they take a picture, they post it in their waiting areas, and they really encourage the staff to get these immunizations. It's not an easy thing, and there's always going to be people who either have an exception or for whatever reason don't want to get the flu shot. But if they make that choice, the choice is they need to be masked up, and it's your job to make sure that that happens. It's the only way that we can protect patients and our other staff. We all know how difficult it is when someone in the office gets sick, because pretty soon everyone's sick, and there's a lot more absenteeism, and we all have plenty of stuff on our plate already without having that happen.
Exactly, Russ. I agree with you. I visit a lot of different providers, and in the last 2 weeks, I have been in agencies in both Connecticut and Massachusetts, and in both of those agencies, I watched as on Friday, the supervisors with staff coming and going in and out of the agency, the supervisors were handing out small baggies of masks to those few people who had, for whatever reason, not been able to get a flu shot or had made a conscious decision not to be immunized. And they were reminding them that spot unannounced home visits would be made, and if you had made that choice, you needed to be wearing your mask. And they gave them advice about how to address it so that they were not embarrassed in front of the patient, but also were sticking to the agency's commitment to get everyone immunized. They were suggesting to those staff, you've made the choice, and that is your choice. However, we have an obligation to protect our patients. And so one of the things that they can do is offer staff a line or a statement they can use when interacting with patients. I don't, my children have a cold at home, and I don't want to pass it on to you. Whatever they might offer them, but something that presents it as tolerance, not intolerance, but still making the point that this entity, this practice, this agency is committed to 100% immunization.
Just an aside, Kathy, I was in a specialty office last week, and I asked the woman at the desk, do you get flu shots? Are flu shots mandatory in your office? They said no, and she said she didn't get one. Yet sitting on the counter was a statement saying that any patient coming in with flu symptoms has to wear a mask. I found that a little ironic.
To say the least. And they clearly haven't considered the impact on their own costs. As an employer running a home care agency with over 300 staff, we looked at the cost of sick time in the winter months from October 1st through April and determined that comparing 2 years side by side, the year that we began mandating immunizations, the sick time and the cost of having to replace those staff in the field, the cost of lost reimbursements for services provided was so large that we saved 3 times the amount of money we spent on the flu shots, and we paid for the shots for all of our employees. So consider the impact it will have on your own costs if you do have a program like this.
Alrighty, well thank you guys for that great discussion. Russ, if you can go to the last slide for me. We did have a few announcements before we end today's call. As you can see from this slide, we are now on social media, so please connect with us on Facebook and or LinkedIn for the latest resources, webinars, and other offerings from the New England QIN-QIO. As you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill it out, we would greatly appreciate it. If you don't have time to fill it out right now, or you're currently sharing a computer with someone else, you'll receive an email tomorrow with a link to the evaluation, as well as the link to the event page on our website. On that event page, you will find the PowerPoint presentation for today. And in the next few business days, we'll also be adding the recording and transcript from today's webinar. So thank you all again for joining. Thank you, Russ and Kathy, for that great presentation, and have a wonderful day.
Thank you.
Bye, Russ. Thank you. Bye, Kathy.
The leader has disconnected. The conference will be terminated in 5 minutes.